is Sunrise Sunset, the Jewish Family in Transition, and I'm Audrey Gordon. Our subject today is talking about aged people, the elderly. My guest is Dr. Sanford Finkel. Dr. Finkel is president of the American Association of Geriatric Psychiatrists. He's chairman of the psychiatric unit in the White House Conference on Aging. He is medical director at Berkeley Hospital in Chicago and also associate professor at Northwestern University in psychiatry. And Dr. Finkel and I are going to talk today about some of the problems and some of the concerns that the elderly have. Welcome.
Thank you.
Sandy, we have often talked about how when people get older they seem to become senile, or that people lose their faculties, and that they have problems remembering things, or that they seem not to be able to think as well. And I think research has shown the last couple of years that that's not necessarily true. I was wondering if you could help to identify what are real problems for the elderly and what are some of the things that are imagined but not real.
Well, there are many facets to that question. One aspect of it has to do with changes in memory that occur that are considered, quote, normal, unquote. And some of the research that's been coming out in recent years is quite interesting. For example, the idea that there are different kinds of intelligence. A certain type of intelligence that's called crystallized intelligence is learning that is based on information we already have and building on it. And that type of intelligence really remains intact through the entire life cycle. Fluid intelligence, which is something that is totally new learning, like some of the computer learning that is done nowadays, actually peaks much earlier in life. But I think that the question of what happens in later life and the memory loss that some people attribute, or senility, which is a commonly termed used, is a grossly exaggerated condition of later life. The best statistics we have are that about 5% of the people over the age of 65 have serious memory loss due to dementia. And in fact, what we have found over the last couple of years in research are that if we took a sample of people that presented with memory loss, that maybe a third of them would have treatable and reversible kinds of conditions.
Isn't it true that sometimes people forget because they're in new situations? I mean, don't you forget things if you're not in a very familiar place? And the elderly are constantly suffering losses and things that place them in new situations. Wouldn't it make it more difficult for them to sometimes always remember things?
Well, it's true generally throughout the life cycle that if a person is anxious, that can and often does impair memory function. So that if an older person is going through, or a person at any age is going through a stressful time, that will have an effect on their concentration, which in turn will have an effect on their ability to remember things that are coming in, to actually register them in the first place.
You know, most people don't realize the elderly are constantly suffering loss, the loss of friends, the loss of relationships, the changes, the losses of identities from retirement possibly. How do we know, how would we recognize in an elderly person what was coping perhaps with losses in the aging process and serious illness, like you mentioned dementia? I mean, you want to give a definition of what the difference is. So.
Yeah, I'd be happy to get to dementia. To get to the point you made just before, first, though later life is a time when people are at higher risk for losses, the idea of late life being a time which is predominantly one of losses is an erroneous assumption. Okay. There are also opportunities for growth, for use of leisure time, for developing other aspects of one's personality and other interests. To be sure, one needs some good luck, and if indeed there are many losses that may preoccupy one's energy. But for many older people, and I think when we talk about older, the idea of what older is shifted. 20 years ago, 65 was considered very old.
Okay.
Now when we talk about older people in the field of medicine, we're talking about people over the age of 85 or 80 anyway. And that group has a much higher risk yet for losses. For the over 65 age group, even for people who are going through retirement, it's for very many, recent research shows, a time of rather good adjustment and an opportunity to do things that people have wanted to do through a lifetime and had not been able to do. The reason that retirement has been so stressful for certain people in this country is, first of all, there are economic losses that take place. And that results in certain tensions and certain decrease in opportunities for those that don't have the financial wherewithal to do what they want. And secondly, there are those people who have put so much emphasis on their work and their work roles that when they retire, they are really left without a sense of identity. And I anticipate this will change. I think this will be one of the positive aspects of women's liberation and men examining other aspects of the personality, that retirement will be even less a problem if the financial aspect is dealt with.
How do you know an elderly person's in trouble? What would you look for?
You mean if some, well,
mental trouble.
Well, being a psychiatrist, there usually is some evidence of it by the time they get to me.
How would somebody else know that? I mean, what should they look for?
All right. Well, that's a very good question. The psychiatric problem that occurs most commonly in later life is depression, and depression is characterized by certain signs and symptoms. People are often hopeless. They're very pessimistic about their future. They have difficulty with sleeping. They wake up early in the morning. Usually the morning is the worst time for them. They have appetite disturbances, often lose weight. And these are treatable conditions. Often what happens in families, for example, or friends of an older person with a depression, is they take a look at the person who has these complaints and they say that either, one, it has to do with aging and you can't do anything about it anyway, or two, what does one expect, because aging is a time of losses and you should be depressed and sad. And so what happens are that these clinical conditions are really not addressed, and not diagnosed, and not treated, so people linger in those states for extended periods and go through undue suffering.
If I understand what you're saying, people assume things about what aging is supposed to be all about, that if people have suffered losses, that they therefore are depressed, or if they seem to have a lot of complaints, that they ought to have a lot of complaints because they're the age that they are. I mean, what more can you expect, sort of thing.
That's the Western idea about aging.
Right, right. But what you're also saying is that this is as treatable as a bad back pain, or maybe that's a bad example, as a medical condition for which you would go to the physician when you're 30 or 35.
The depressions, yes, indeed.
Yeah.
The first point you raised had to do with stereotyping, and although indeed many people, the longer you live, the more the chances are something untoward will happen. And indeed in late life, some people go through severe losses at different stages. But for many of the years that people have in later life, there are opportunities available to them, and that those opportunities sometimes are realized, but yet we still have this idea that late life is only a time where you're dealing with your losses and being depleted of your energies. In the second point, indeed, there are clinical conditions which can be treated. Even dementia, which you mentioned before, though we don't have a cure at this point for, the senility is what commonly used as a lay term. We don't have a cure for it, though there is much interesting research going on. But we do have methods to keep the person at optimal functioning. What's so important is that the family understand what is part of the condition, if indeed they have a parent or a spouse with a dementia, what's part of the condition and what is not part of the condition. People that are demented may develop depressions, anxiety states, which are treatable conditions. They may develop medical problems which worsen their mental condition. And when the medical problem is treated, their mental condition improves, not 100%, but to the point where it's only the dementia that's causing the interference.
People do have to realize that when they're taking medications and they're elderly, that the medications themselves may interfere with their normal mental processes too.
To be sure, older people are more apt to be on medications, first off, and secondly, because of changes in their own physiology, they're more apt to have reactions to medications, more severe reactions, and medications must be used very cautiously. I think that at last this point is getting through to the general public and to physicians, and in some ways we're seeing the backlash of it, whereas in as much as some older people who need to be on certain medications which can help them are reluctant to do it for fear that they'll become addicted to it, or they'll develop side effects, or if they have a minor side effect, they'd rather discontinue the medication sometimes, even at the risk of maintaining a painful mental state.
Sandy, in elderly Jewish people, they're not as tuned into modern therapies and the ideas of going to psychiatrists for help. I mean, that has been seen as a stigma in Jewish family, that somebody needed help. How do you handle that with some of your older patients who've been told that they have to be with you or else they're going to be in real trouble?
Well, first off, I don't think it's Jewish elderly. In fact, it probably is collectively less with Jewish elderly
I'm glad to hear
than with other ethnic groups. maybe partly because
so
many people in the mental health field are also Jewish. For the most part, the anxiety is, and the stigma, I think, is overrated. If an older person is going through a period of suffering, let's say with a painful depression, what they're interested in is getting relief from the suffering. And although the idea of psychiatrists and what's this about, and you think I'm crazy, these issues come up. In actuality, when I see an older person, regardless of the objections they have before they come to see me, once they come to see me, there really is only one question on the table. Can you help me or not?
Right.
Does it make sense what you're telling me, or does it not? And the older person will judge very quickly. The person with even great anxiety about seeing the psychiatrist, if there is some rapport and some feeling that maybe the doctor has something to offer, the person will come back, and it's not an issue. The difficult part is sometimes getting the person into the office, and sometimes I will talk with family members. If it really sounds like a parent or a spouse needs to be in to see me, I'll talk with them about strategies to at least have an initial evaluation. After that, it's really predominantly between the patient and the doctor.
So once you get them into the office, then they're on their way to being helped.
In most cases, yes. I mean, there's some cases where it doesn't click, but in most cases, yes. But at least you know. It's different in terms of doing psychotherapy and working with older people. You know very quickly, usually in the first 1, 2, at most 3 sessions, whether or not you are going to develop a therapeutic alliance and be able to help them. With some of the younger patients I see in my private practice, it may take months before we know we have a working alliance and a trusting relationship. But there is not that amount of lead time in working with older people. You get right down to business.
Right, that's right. They do get right down to business.
Absolutely.
And less nonsense about the whole process. They're really very much down to earth. I know that you've done a lot of work for the Council for Jewish Elderly and are very familiar with their programs. I'm wondering, what are the sorts of things that are on the planning boards for elderly, some of the things that have been done for Jewish elderly? I mean, what's the 80s going to hold for people who are older in our civilization?
Well, there's several questions in there.
Yeah, I always ask a couple.
The Council for Jewish Elderly, which is based here in Chicago, is certainly a unique and outstanding organization where there are many, many dozens of services offered to older people residing in certain geographic areas of the city under one administrative roof. The coordination, the ability to follow people through the health system if they have to go into a hospital, being able to provide housing, nutrition. If we take the program collectively, as a psychiatrist, I would view it as a primary preventative mental health program, besides offering a wide range of very important services in their own right. I could give you example after example of how well the system works. Just for one woman moved into a apartment in the area, older woman, a nervous, high-strung woman, but a woman with no psychiatric history, about 70, with her husband, and there was a stereo blaring. One of the neighbors kept them up till midnight. It was unacceptable. So they complained. The landlord said, tough, you have 11 months to go on your lease. The woman was referred to me. We got legal services involved. She needed some medication short-term, got him out of the lease, got him elsewhere, and we were able to avert what I think would have been a psychiatric problem over. Yeah, it really was a. It was a mini crisis. We were able to avert something even more in a short period of time, and she did fine elsewhere. In terms of the 80s, I think these are the best of times and the worst of times in a sense. The emphasis that has been placed on aging, and with more older people in our country, and with our being an aging society, more political clout, etc., there have been a lot of opportunities and a lot of very positive directions. On the other hand, we have sometimes now where there are cutbacks in certain programs and uncertainty at a whole variety of levels in terms of social services. But I think there's certain trends that will continue, and I don't see any way of stopping them. I think we're going to see trends toward using older people as a national resource.
How are we going to do that? I mean, what are they going to be resourceful to do?
Well, I think that with more people having the wherewithal to live productive lives and wanting to live productive lives, well past the age of 65, the kind of traditional artificial
well, Social
age.
Security age is really what it is.
And that, of course, too, with Social Security, the situation being what it is and mandatory retirement being delayed, there has been some encouragement to pass legislation that would allow people to continue to work indefinitely as long as they wanted to work. So we're going to see that as a way of using resources in the work area. But also in terms of civic activities, I think we're going to see times in the relatively near future where older people will be, for example, brought into schools and talk about not only areas of interest they have, but also reflections on world wars they lived through or economic depression.
You mean an oral history for the kids?
Just as an example. That's a resource that could be used throughout the life cycle and throughout the 12 years of high school and even beyond that, which would, I think, have enormous potential of being valuable, as well as shaping attitudes on the parts of students about what older people are about.
I think that's very important. I think that we segregate age groups all along the line, and the generations don't know about one another. I know you agree.
Sure.
You said something about computers. We were talking earlier. What did you mean?
Well, the advent of electronics and computers and the advances that have been taking place, I think, open up just all kinds of new and innovative directions for us. For example, let's say you have an older person who has a heart problem and some diabetes, and they're taking a heart medication and maybe something for blood pressure and a potassium replacement, something for diabetes, and maybe a sleeping pill and a pain pill. You go on, and there are many problems with that. First of all, a person may forget what medication they've taken and not taken. Certainly with the number of pills they're taking, you don't have to be demented to forget when you took what. Secondly, some people are so preoccupied with when they're going to take their medication and whether they took them that sometimes they spend most of the day being anxious that they're going to forget to take their medication. So, in many ways, it's a problem. And now, for the first time, we have the technology, at least, where we can do something about it. We can program a little mini computer, if you will, to have a printout, or at certain times they will go off. The person will push the button. Now it's time to take your digitalis, take this and that, push it, goes off again. And in that way, electronics has done what I've encouraged pharmaceutical companies to do for the longest time, which is find a way where people can administer to themselves the medication they need without having to be extremely preoccupied by it. And of course, that'll increase compliance as well. Another example, there are systems now where electronically people can be hooked into emergency rooms. How many people go into nursing homes that don't want to go into nursing homes, but they're fearful of going to sleep at night because they have a heart problem? They're concerned, what is going to happen if I go to sleep? Or they are dizzy periodically. What happens if I fall? Will I be left alone for days? Now, if they can carry around a little something with them and just press a button, and it goes right into the emergency room. And a very short time later, people will come in and provide them with the emergency care that they need.
In other words, what you're talking about is like a hookup directly to the emergency room of a hospital for someone who lived alone.
Yes, there's scores of these now around the country, and they are going to be growing.
What are they called?
The group that's been in on it right at the ground floor is Lifeline Systems, and they have hospitals throughout the country. But there are other groups as well, that other companies that are into this and trying to get hospitals to work with them to provide these types of services.
What does this unit look like? I mean, I'm curious. This sounds too good to be true.
Well, the unit is a relatively small thing for the patient to carry around.
Right.
But there's a huge computer, which I wouldn't even begin to try to understand or explain. That's part of the hospital system. It's not huge, but I mean, it's more complex. That monitors the people in the community that have this. Along another line, they now have, for example, in Columbus, they have a talk show where a person can actually talk to the people that are on the show at that time.
Right.
Well, it's just a matter of time until we get the technology in order whereby we may have computers that have data on people. There may be companies that run computers with data on people that will hook people up so they can talk to each other. So, for example, people that are homebound may be able to talk on television with people in different parts of the country or the city who have similar ethnic backgrounds or similar interests. In fact, there may even be a time when, as a doctor, I'll be able to see a patient. During the winter, it's hard for patients to come to see me sometime. The telephone it's better than nothing, but being able to see even over a television is better than just talking over the telephone. Et cetera, et cetera. So these are some of the things that I think we can see in an encouraging way, which will be developing as the costs for such systems come down and as they become more accepted and
so you're saying that electronics might help to make the elderly less lonely, less isolated, more secure in their own environments, and more plugged into our society, actually.
Another way,
quite literally, I think.
Yes, but in another, also plugged in our society, because I think now we're seeing people that are working at home, that are able to work with their computers at home. People that would have to relocate, for example, are able to work at home, and in fact, sometimes that means a husband or a wife or both would be able to be home. So if they have an older parent there, that would provide some supportive services right there on the spot, which you wouldn't have if both people had to go downtown to work every day, which has been more traditional. And we're going to see more of this, where one or both people will be able to be home and do their work in their home with the use of computers.
So in a sense, you're saying it might draw the generations together.
Yes.
But let's talk a little bit about the generations, especially when they are together. Many people have older parents, perhaps both parents or a single surviving parent living with them, and their problems crop up from time to time. And one of them I know from friends that have talked to me is that their mothers or their fathers are dating, or they're seeing women or men, and the children have a lot of trouble with this. I mean, how would you speak to not only elderly people about this part of their life and romance, perhaps after having had a long marriage which has ended for some reason, or even to their children to kind of reassure them, Mom and Dad are stepping out on them and they never saw that before? What do you have to say about that?
As usual, you're asking
40 questions
that
was.
go into several associations. One association is that we're seeing, whereas less than 100 years ago it was a rarity almost to have a 3-generation family, we're now seeing 4- and 5-generational families. In fact, not long ago, a 79-year-old woman sought me, my assistance, for help with her mother, who was in her mid-90s and having some difficulty with memory at that point in time. Yeah. In terms of dating, I think we're going to see a change. We get into old questions about Oedipal issues and parents having sex
in front of their kids
nature.
and all that.
There are many problems. There are many problems that come forth for the adult children. One problem is that of the parent may be idealized, the dead parent, and the idea of a mother going out with somebody else after
disloyalty.
Being disloyal. Sometimes there are legal issues in terms of will, or will mother remarry, and things of that nature. Sexually, like I mentioned, there's the traditional Oedipal kinds of conflicts, which have created problems in doing research with older people. Not only have there been the barriers of the researchers themselves and the barriers of older people, but more predominantly the barriers of the adult children of older people who have objected to participation in Masters and Johnson type studies. But we have increasing information about sexuality in late life, and the things that seem to determine whether or not older people remain sexually active are, first, whether there's the availability of an interesting and interested partner. Secondly, whether there's at least a modicum of physical health. Somebody that's very infirm or Parkinson's, not able to move, is going to have problems. On the other hand, people that have had heart conditions can indeed be very active sexually. And finally, there's the history. And what generally is true is that if a person has been active sexually and interested sexually earlier in life, they maintain that interest in later life as well.
So it's been who you were all along that determines perhaps the kind of sexual activity that you'll be engaged in as an older person. The kids do have problems with this. It's fascinating to see that they don't want to participate because we have trouble thinking of our parents.
But I think, again, this is going to change. I think that attitudes are changing. If you realize that adult sexuality has been studied only for about 100 years, and childhood sexuality for about the same amount of time, a little less, and adolescent sexuality maybe 40 years, the elderly really have only been studied over the last 25 years. So it's a relatively new thing. But I think also that attitudes that people have more generally about sexuality are indeed going to affect older people, and all the more so as people with those attitudes become older themselves. And I would anticipate, whereas you have more opportunities, and older people have more opportunities, and there may be more alternative lifestyles sexually, and may feel free to express that there will also be more conflicts that go along with that.
We're all aware of elderly people today. They come out of certain amount of experience, depression, World War I, immigration, and so forth. What are we going to be like when we're old? I mean, what's it going to be different for us in terms of how we're going to view our aging? What's the society doing to change notions about it?
Well, I don't know if society per se is, unless you're talking about some of the legislation that's been passed. And
yeah, I mean, attitudes. I mean, how are we going to view our aging differently? My grandma says she wishes she was dead already because she doesn't feel well, there's nothing for her to do. She's 89 and not in good health, but there are a lot of people who just feel that they've lived their life and it's over. They have, women especially, having had no education, no training for business, elderly now. But our women are different, this society's women. How's it different?
Well, when you consider that in 1970, 6% of all people over 65 had high school educations at all, you know, that obviously we're a more educated society. Hopefully we will have learned from our own parents and grandparents' lifestyles, and maybe we'll have other kinds of problems that they don't have, and I think there's some evidence for that.
Well, what would some of those be?
Well, like, for example, divorces, which are more commonplace,
so
the willingness to shift from oh, go ahead.
No, I'm saying is that there'd be less of a cohesive family unit that our grandparents knew. You know, they always had their children around them. They knew where their husbands were, where their sisters and brothers. So there's going to be a less stable family background.
That's what we've seen to date.
Mm-hmm.
But again, in my more optimistic moments, and looking at the electronics and computers and things of that sort, and perhaps some other changes just in terms of the women's lib movement and the effect on men, that we may see a return to a more cohesive family setup as time goes on.
Mm-hmm. But
it's hard to anticipate.
Is it going to be better for us? I just want to know that it's going to be better.
I wish I had my crystal ball. I think we'll see new opportunities. We talked about civic opportunities. I think someone will come along with ideas about new athletic opportunities for older people. There will be more innovation in terms of work. We'll have shared jobs, second careers.
Are we going to be healthier? I mean, is that in the cards too?
Well, there's a lot of evidence to indicate that that's so. Certainly heart conditions. We've made some major breakthrough in terms of cardiac disease, cancer, hopefully in the near future. People are living longer. Respiratory advances have...
Longer and healthier.
Longer and healthier, yes. Open heart surgery for many has meant a different lifestyle. How quickly these advances will come, you know, it's hard to say.
But everyone's hard at work at that.
Everyone's hard at work at that.
If you had to give a word of encouragement to people out there who may think that their life was over right now, what would you say to them? I mean, what would you say to get them up and going? And people
who are you talking about?
The elderly, I mean, however we, in 5 seconds, quickly, a word.
5 seconds. I think that you have to rely on the individual. It depends on the individual. And to make a blanket statement, you'd have to know what the person was feeling so negatively about. Whether it was part of a mourning reaction that was short-term, whether it was a clinical depression, whether it was a characteristic pattern that had existed for years and years and years. And that, depending on that,
we have lots to talk about, and I'm so glad that you came. And it's been a real pleasure. This is Audrey Gordon. And this is Sunrise Sunset. My guest today has been Dr. Sanford Finkel, and we have been talking about the elderly. Thank you.